This video is about safety netting for suspected cancer in primary care. I'm Dr. Rhian Thomas, a GP in Runcorn and Cheshire and Merseyside Cancer Alliance GP place-based lead for Halton and Knowsley. This video will cover what safety netting is, what guidance there is about safety netting for suspected cancer in primary care, why safety netting is important, some case examples and information about resources available to support safety netting. Safety netting is something that forms part of most general practice consultations in one form or another. But when we think about what we mean by safety netting, there are multiple elements to consider, such as its use as a consultation technique, as a tool to manage diagnostic uncertainty, a system of mechanisms to inform patients of red flag symptoms and provide information to ensure patients represent as appropriate, a contingency plan, a means of empowering patients, observation for and following serious illness, the active monitoring of patients, follow-up and monitoring of investigations and urgent referrals, an administrative process, and a medical legal protection for clinicians. So safety netting is a vital part of primary care work, and evidence suggests that the long-term benefits to practice workloads and patient diagnostic pathways can override any short-term challenges of establishing processes. Safety netting is a concept that evolved from Roger Neighbour's consultation technique. He asked 3 questions. If I am right, what do I expect to happen? How will I know if I'm wrong? And what would I do then? And safety netting has since changed from a consultation technique to a specific recommendation. In 2011, a paper on improving early cancer diagnosis in primary care defined safety netting as a diagnostic management strategy that ensure patients are monitored throughout the diagnostic process until their symptoms or signs are explained and the results have been acted upon. Further recommendations from the literature are that safety netting is more than solely the communication of uncertainty within a consultation. It should include plans for follow-up, as well as important administrative aspects, such as the communication of test results and management of hospital letters. And that safety netting is not just for red flag symptoms requiring referral on suspected cancer pathways immediately, but that practice systems should enable active follow-up of low risk but not no risk symptoms. This could reduce delays in diagnosis without increasing GP workload. And NICE NG12 suspected cancer recognition and referral guidelines make specific recommendations about safety netting in line with this. Safety netting can be important at multiple stages of patient care, from first presentation, subsequent presentations, investigations, referral and diagnosis. And safety netting can play a vital role in ensuring delays are minimised at every interval within this. Some of the challenges in safety netting have also been highlighted by research findings. It's been found that practice safety netting varies depending on perceived cancer risk and perceived patient factors, time pressures and work patterns. GPs often use bespoke personal strategies developed from past issues, and there can be a lack of knowledge of colleagues' practices and variation within organisations. The long-term value of many reliability-enhancing practices such as safety netting are not always easy to see, while the short-term costs are often highly visible. And patients may not recognise safety netting as an established part of consultations and therefore may not understand what the clinician is trying to communicate, especially if it's left till the end of a consultation. So to summarise the guidance around safety netting, there are 3 main elements to consider: patient communication elements, clinical consultation elements, and practice-wide elements. and we should be considering these not only in urgent suspected cancer referrals, but also in urgent diagnostics and low risk but not no risk symptoms. I'll expand on these elements more in some case examples. These are fictional examples inspired by real experiences from Cheshire and Merseyside. So if we consider the case of a 61-year-old man presenting to the GP with increased urinary frequency and nocturia. A full history is taken, he's examined, including a prostate examination and a urine dipstick. Nothing abnormal is found. A supportive discussion about PSA testing takes place, and by mutual agreement, a PSA is arranged. We can look at the safety netting elements in this case in the three categories of patient communication, clinical consultation, and practice systems. There are patient communication elements within the supportive discussion, including the provision of verbal and written information so that the patient can refer back to it, including any adaptations in the communication of this for patients' individual needs. How to access phlebotomy also needs to be communicated effectively, and how to access results. Also, the importance of obtaining these results. What the next steps might be if the result is positive should form part of the supportive discussion. Expected timescales for results should be communicated, and the patient empowered to seek review if they don't hear within a specified time frame or if symptoms worsen in the meantime. There are clinical consultation aspects, and these are things that need to be done during or shortly after the consultation. In this case, that would include the requesting of the PSA correctly, ensuring the patient contact details are up to date, and ensuring accurate contemporaneous notes, which would allow for continuity if another clinician was consulted prior to follow-up. In this case, a follow-up phone appointment was planned, and this was booked by the GP and forms part of the safety netting. A safety netting template was in use by the practice to track urgent diagnostics, so this was completed by the GP during the consultation. In terms of practice system elements, the practice has ensured there is a practice-wide system for tracking of urgent diagnostics using one of the available safety netting or fast track templates and the search packages associated with this. This means that if the patient didn't attend for their bloods or follow-up, this would be identified. The PSA results come back raised significantly for age range, and the patient has follow-up the next day as planned. Following discussion, referral is made on an urgent suspected urological cancer pathway. So considering patient communication elements of this, there's the explanation of the nature of the referral and the importance of availability for appointments and investigations. There's the provision of written information that the patient can refer back to, and in this case the patient requested this was sent by text. There's the communication of information around timescales of what to expect next, and who and how to make contact if they haven't heard within a specific timescale. And discussion of clinical changes that might suggest sooner review is needed. There are the clinical consultation elements, which include completing the referral in line with practice and locally agreed processes, and ensuring contact details are up to date again. There's completing the safety netting template, so the tracking for the PSA can now be completed as the patient has been informed of the result and it's been actioned. And tracking can start for the urgent referral. It's important to make sure the patient has understood and is in agreement with the plan, and consider any particular adaptations that are required for this patient, such as scheduled follow-up or monitoring. And for practice systems, there's the use of the practice safety netting that element of the tracking can be completed, and if there was no record of this within a set time frame, this could be identified, looked into and actioned. We consider the case of a 64-year-old female presenting to an AMP in general practice with a cough and green sputum for 4 weeks, with gradually increasing breathlessness prior to this, and she's an ex-smoker. If we look at the details of this case, it gives us examples of how practice-wide safety netting processes can reduce delays when an urgent chest X-ray was not attended. We consider the case of a patient with a suspicious-looking skin lesion. In the details of this case, we can see how a computer issue for a locum GP meant that an urgent suspected skin cancer referral was not sent as intended. However, due to the patient communication elements of the consultation, which had taken place, informing the patient of the nature of the referral and the expected timescales, together with practice-wide safety netting processes the locum clinician had taken part in, this was able to be highlighted and corrected with minimal delay. So when we're thinking about a practice-wide system for safety netting, there are several points to consider. It should be IT rather than paper-based, as it needs to be accessible to all relevant practice team members and not dependent on paper. It needs to be GDPR compliant, digital and secure. It needs to be supported by training resources to support standard practices, not just within practices but across areas, and make it possible for new users and locums to adopt the practice-wide systems. It should be managed by a team so that the processes are not dependent on any one individual. And it should be easily auditable to monitor its effectiveness and usage, and linked to the clinical system so that standard codes can be used and embedded within existing systems to avoid multiple logins. And it should support safety netting of urgent diagnostics as well as referrals. There are resources to support all aspects of safety netting for suspected cancer in primary care at Cheshire and Merseyside Cancer Alliance Cancer Academy. In summary, safety netting is an important element of consultation and practice processes for patient safety in primary care early cancer diagnosis. Safety netting is more than just the communication within the consultation, although this is an important element. It should also include administrative elements and, where necessary, follow-up communication. Safety netting processes should be practice-wide. There are digital resources to support safety netting in primary care available at Cheshire and Merseyside Cancer Alliance Cancer Academy.